Hello everyone, welcome. Thanks for joining us for tonight's COVID-19 vaccine update number 2, presented by Hunter New England Central Coast PHN and Hunter New England and Central Coast local health districts. So my name is Charles Broadfoot and I am a professional development officer with the PHN. I'd firstly like to acknowledge the traditional custodians of the lands in which we're all meeting tonight and pay my respects to elders past, present and emerging. So please type your questions into the chat pane throughout the session tonight. We have allocated time for a panel discussion after the main presentations. Tonight's session is being recorded and the recording will become available on our webpage from tomorrow. So you just head to our homepage and click on the Education tab. You will also see an evaluation survey pop up when the webinar ends. If you could just take a moment to fill this out before you log off, we really appreciate your feedback. So I'd now like to hand over to John Baillie. John is an executive manager here at the PHN and he'll introduce tonight's presenters and panelists. Thanks very much, John.
Thanks, Charles, and welcome everyone. Thank you to our colleagues at the local health districts for their support with this. Particularly like to thank Dr. David Durrheim and Dr. Kat Taylor, who are going to provide us with some update in terms of the technical aspects and the epidemiological aspects of the vaccines. And also welcome Patrick Cashman, who's going to help us with some of the questions around the vaccination itself and the regulations and approvals there. So again, thank you. And just to reiterate, if you can type your questions into the question bar, we'll try and get to those as
All right, thank you for the introduction, John. So we might hand over to you now, Kat, if you'd like to share your screen and start the presentation.
Charles, can you see my screen?
Yeah, that's great.
Okay, fabulous. All right, well, thanks everybody. Thank you for your time and attendance. I know that you've all been incredibly busy lately and possibly even, busier than this time last year. And we're certainly in for another roller coaster ride. I hope that some of you have had the chance to have a bit of rest and relaxation over the past couple of months, as we are in a very fortunate position with COVID-19 in Australia. So we've got a huge privilege of being joined by Professor Dave Durrheim and also Patty Cashman tonight, and I'm personally looking forward to hearing what they have to say as well. But I thought I'd just kick off with a quick overview of what's known with the vaccines currently and the sort of current state in Australia, and hopefully we'll have enough time allocated to get into all of your great detailed questions about what this all means. So I thought I didn't want to spend too long on the slides, but I did just want to take a moment to pause and reflect on the current epidemiology. Given that we are in such a fortunate position in Australia sometimes, and with the level of COVID fatigue which we're all experiencing, it is easy at times when you go to the shops or when you meet up with your friends to forget that we're in the middle of a global pandemic. But indeed we are. Globally, there have been 106.8 million cases confirmed worldwide, and more than 2.3 million deaths, which is just tragic that we're talking in the millions for both of these figures now. As I said, in Australia, it's quite a contrast. So we are really quite close to having achieved effectively no community transmission. However, as expected, there is the ever-present threat of COVID-19 at our borders. And as we're seeing lately with this latest evolving situation at the Holiday Inn in Victoria, which has led to some additional alerts and healthcare screening going out for people that have been in Melbourne at that particular Holiday Inn. Between I think it's the 27th of January and the 7th of February. But yeah, essentially there will be incidents like this from time to time, but we are entering into a very fortunate position at present. And in New South Wales, our last locally acquired case was back on the 16th of January. So where both the Avalon and the Inner West clusters have been closed off with, more than 2 incubation periods since the last associated cases. And interestingly, our sewage surveillance has also just flicked negative in the last couple of days, other than the very centralised Sydney catchment, which obviously would include sewage from the hotels that are quarantining travellers. In line with the new epidemiological position that we're in, there has been an expanded program of return traveller testing at day 16. So this is after people have been discharged from hotel quarantine, that they are recommended to have another test at day 16. And you would be aware of that person that was picked up through that testing. Of course, there's been a huge amount of investigation that's gone into that case of the last couple of days. And current thinking is that it's looking to be a historical case, but there is ongoing investigation. But we're in an incredibly enviable position compared with the rest of the world, but we are still very much in the grip of a global pandemic, which is why it is so critical and so welcome that we have safe and effective COVID vaccines becoming available shortly. Of course, the other cause for concern, I suppose, with the evolution of this vaccine, of this virus, is the variants of concern. And there are several, and so, with any RNA virus, mutations are anticipated, but of concern are mutations which give rise to strains which in turn demonstrate, I suppose, phenotypic characteristics of, things like increased transmissibility, leading to obviously the increased risk of outbreaks and spread, and control measures not being as effective. And then, of course, the potential impact that mutations may have on the effectiveness of vaccines that have been developed. So just to highlight a few of the key lineages that are being discussed currently, the B1.1.7 lineage, which consists of a handful of mutations and was first reported in the UK, but has since spread to 62 other countries. And certainly initial reports did suggest a potential for increased transmissibility, but concerningly in more recent weeks, we've seen a potential for increased disease severity as well. And in vitro studies, whereby serum has been tested against virus strains in vitro, has shown that neutralization activity may be slightly diminished from vaccine-induced antibodies. The other variant that has rose to prominence recently is the B.1.3.351, which was first found in South Africa, and certainly worryingly increased transmissibility, but also the preliminary in vitro and in vivo reports of decreased protection by particular vaccines, and the AstraZeneca vaccine against mild to moderate COVID-19 disease with this strain. And then, of course, there's also the strain that was first reported in Brazil and has also affected Japan, the P.1. But the mutations will continue with SARS-CoV-2. It's really just a matter of, and our technology is so advanced now in terms of being able to in a very sort of granular manner, be able to type the whole genome of these viruses and be able to really track that change over time. But it will come down to really marrying that alongside the epidemiology of what it actually means for both the clinical picture as well as the public health significance of these strains. So I will just move on now to the vaccine development landscape. So it's really quite an unprecedented time in terms of vaccinology, a great boon for the field in terms of accelerating vaccine development and also the use of novel approaches. So there are currently over 200 candidate vaccines that are in development worldwide. Although there are sort of trial results being published all the time by social media, it seems, there are only 4 vaccines that currently have phase 3 trial data that has been published in peer-reviewed literature. Unfortunately, the global pandemic has brought out some of the uglier sides of things like vaccine nationalism, and we have seen and have potentially experienced the impacts of purchasing agreements by large, well-developed nations. And this was an article from, I think it was sometime last year, which showed sort of the best and worst supply, but it really sort of lines up with what we're seeing in terms of the United Kingdom has pre-purchased a lot of doses, in fact far exceeding the number of doses per capita that would be required. And more recently, The Guardian published this infographic, which, sorry, I'm just having to move my little presenting panel around to be able to see the slide. This infographic, which demonstrates, so the coloured square reflects the vaccines that have been pre-purchased, and the different colours represent the different vaccines. But then the hollow black line square reflects the population of that relevant jurisdiction. And you can see that you know, many of the developed nations have entered into purchasing agreements sort of far outweighing the amount of their population, leaving, unfortunately, developed nations to not have enough for their populations. And we are seeing this start to be resolved, but unfortunately, this kind of behaviour, you know, just does exacerbate problems globally for everybody. In terms of Australia, we have entered into, I believe it's 4 different purchasing agreements. So we are a signatory to COVAX, which is a global vaccine purchasing and allocation initiative, which Dave could certainly speak to the inner workings of. But we also separately have an agreement with Pfizer, which is for the purchase of 20 million vaccine doses, should I say. Also, there's been an agreement with AstraZeneca for the purchase of 53.8 million doses, noting that, you know, 2 doses per person, so 25 million population. And notably 3.8 million of those are to come from overseas, but to be supplemented with 50 million that are actually produced in Australia. That, of course, is subject to regulatory approval. So Pfizer is the only one that has regulatory approval currently in Australia. And then we also have an agreement to purchase Novavax vaccines, and I believe that's something in the order of 50 million. But yes, so that's sort of the state of the vaccine development and purchasing landscape. And we can see that, you know, a lot of countries that are obviously in much more difficult positions than ourselves have really been speeding to achieve good population coverage of the vaccines. Israel has been at the forefront of that charge, and I think it's sort of close to 70% now of the population that is vaccinated, and there is some emerging data suggesting an impact on transmission from that level of coverage as well. So that's very promising. And then you can see as well, I'd certainly recommend to you the Our World in Data website, which gives great real-time data on the global progress of the pandemic, both cases, deaths, as well as vaccination coverage and some other interesting statistics. So there have been more than 128 million vaccine doses administered worldwide, and there is a huge amount of data, particularly relating to, you know, post-marketing surveillance, so safety data relating to all of those vaccines being used. And, you know, in the era that we live in now of big data, it's great that we can have access to all of that information in such a timely way. I won't spend long on vaccinology. I'm sure many of you heard Patrick's excellent talk on some of the mechanisms of action of vaccines against SARS-CoV-2, but I just quite liked this little sort of schematic diagram of some of the approaches towards vaccine development that are typically used and have been used in SARS-CoV-2. So that at the center, you've just got a little sort of schematic diagram of the virion of SARS-CoV-2 with that spike protein we've all come to know and, well, I won't say love, but become very familiar with, and certainly most of the, I think all of the vaccine candidates have really targeted that spike protein in some form or another. So for example, up the top left, you'll have things like protein subunit vaccines, which will contain broken up fragments of essentially key antigenic components or proteins. And the Novavax vaccine, for example, is a protein subunit vaccine. We'd also be quite familiar with, you know, whole virus vaccines, you know, for which contain basically attenuated or weakened strains of virus or inactivated or killed virus. We don't have any SARS-CoV-2 vaccines that actually fall into that category. By far and away, most of them have adopted novel approaches. So really exciting technology in terms of mRNA vaccines and DNA vaccines. So these are vaccines that work by actually delivering the genetic code for our cells to manufacture the antigenic components, which in turn are presented to the body and generate the immune response. So messenger RNA is one means of doing that, and essentially the messenger RNA is engulfed into the cytoplasm and just uses the cell machinery to spit out, copies of the spike protein, which in turn creates the immune memory. But the mRNA itself degrades very quickly. Further upstream of that is DNA vaccines. And then down the bottom, we see also viral vectored vaccines. So these are vaccines which use other viruses, so things like adenoviruses, as the package which contains the genetic information. So it's the virus which gains entry into the cell and then delivers that genetic information to, again, use our body as the factory to produce the antigenic components. And these can be either non-replicating or replicating, so as in the adenovirus itself can either reproduce itself or not. So that's just a nice overview of how vaccines for SARS-CoV-2 have been designed. Focusing now on the Australian candidates. I'm sorry, I just have to move this window. It's quite irritating. So the key front runners being discussed at the moment are obviously the Pfizer vaccine and the Oxford AstraZeneca vaccine. So just quickly running through the side-by-side comparison, they do have slightly different mechanisms. So the Pfizer vaccine is an mRNA-based vaccine. And these are very safe and very efficacious and quite straightforward to produce in a lab setting, which is fantastic. The Oxford AstraZeneca, on the other hand, is a viral vector vaccine, so based on a simian origin, non-replicating adenovirus. And certainly adenovirus-based vaccines do seem to have quite a robust delivery into the cell and subsequently immune response. There is a difference, obviously, in the storage of these two vaccines, which leads to quite different logistical constraints. And so the Pfizer is the one that needs to be stored in deep freeze, so minus 70 degrees, whereas Oxford AstraZeneca subject to normal cold chain of 2 to 8 degrees. There's still some discussion in terms of the optimal dosing schedule. So in the phase 3 trials, a 28-day dosing was used for the Oxford AstraZeneca, 21 days for the Pfizer-BioNTech. But there's now discussion that there's a greater level of efficacy seen with a prolonged interval between the prime and the boosting dose for Oxford AstraZeneca. So there is still discussion in terms of how that will actually look if and when it gets implemented in Australia. Now, efficacy, I suppose that's a hotly debated conversation, and it has been, I suppose it's important to also consider what the endpoints are actually being looked at when discussing efficacy, and also worth, I suppose, pausing to think about the objective of Australia's vaccination campaign, which is, at this stage, we're not in a sort of out and out outbreak with health facilities overwhelmed. We're so fortunate in that, we're in a much more controlled state in Australia. So the objective at this stage of the vaccine rollout is really to protect those at highest risk of contracting COVID-19 from developing severe disease. So, people that are most vulnerable to contracting severe disease if they are exposed to coronavirus, and then also protecting people who are most likely to be exposed to coronavirus. So, the intention is not to get herd immunity in, the next sort of 6 months or anything like that. It's really just about having, quite an intentional rollout that is phased to protect those at most risk. And so in terms of efficacy against The primary endpoint in trials for both Pfizer and Oxford AstraZeneca was protection against symptomatic COVID-19. So 95% for Pfizer, 70% for Oxford AstraZeneca, although there was a range in efficacy because that was pooling the results of several different trials. And there was a slightly modified schedule that was used in one of the trials which showed higher efficacy, potentially pertaining to the increased dosing interval. Or perhaps it was due to sort of low dose, standard dose. That's still to be established. But anyway, so symptomatic COVID-19, both are quite efficacious. Severe COVID-19, both are extremely efficacious and almost equivalently so. So Pfizer-BioNTech was extremely protective against severe COVID-19 after just one dose, and Oxford AstraZeneca reported in their trials 100% protection against severe COVID-19. So that's really great news. In terms of SARS-CoV-2 infection, so whether the vaccines protect against actually being infected with the virus, it's unknown for Pfizer, and there are some preliminary but not peer-reviewed reports from Oxford AstraZeneca of those sorts of levels of protection against actually being infected, which is intriguing and promising in terms of potential control. The other key component is safety, of course. So in terms of the adverse effect profile, what we're seeing emerge internationally is a very reassuring and acceptable safety profile, very similar to other vaccines. For Pfizer-BioNTech, it does appear to be slightly more reactogenic. So the CDC reported an anaphylaxis rate from their first couple of million doses of 11 per million. And of course, there was the investigation following the deaths that were reported in Norway. So the TGA were involved in that, reviewing that investigation, and concluded that there was no specific risk to the elderly from the Pfizer vaccine. So it's possible that those deaths were due to other causes, and although they followed vaccination, they were not causally related. As I said, Oxford AstraZeneca, there was an acceptable safety profile. There was somewhat less evidence of effectiveness in the older age group, which has led some countries to adopt a different strategy of not using that vaccine in older populations. But again, there's also a whole discussion, which I'm sure Dave would be happy to speak to, in terms of differences between efficacy and effectiveness in a real world situation. So just honing in again a little on the commonly reported adverse events following immunisation. These were studies that basically looked at symptom diaries, so people who'd received the vaccine actually being asked to record, each day a diary of their symptoms and report on symptoms. So as expected, most people did have a bit of a sore arm, which you would expect with a lot of vaccines, predominantly mild, and all resolving sort of within the first couple of days of having received the vaccine, onset, within about a day or so of receiving it. There were some systemic symptoms reported as well, most notably fatigue and myalgia, and in AstraZeneca, headache. The key difference, I suppose, between the two in adverse event profile reported was that APHEs appeared more common following the second dose of the Pfizer vaccine, whereas in AstraZeneca, APHEs appeared to be less common following the second dose. So I'll just show you, I don't expect you to read these graphs, but it's just you can sort of eyeball the histograms of the adverse events reported for first dose versus second dose and see that there's less yellow on the right-hand side of the screen. And that was for AstraZeneca. And interestingly, it seemed that younger populations, so the 18 to 55 year age group, did tend to report a higher frequency of adverse effects compared with the over 55s. And then a word on vaccine safety surveillance. So of course, this is a critical component of any vaccine implementation program. So there are a number of passive systems that are already in place in Australia. So you'd all be aware of the mandatory notification requirements for adverse events following immunisation, APHEs. So there is a passive reporting system through the TGA for any suspected APHEs. There are also a number of other passive systems in place. There's the paediatric adverse effects surveillance system, which is a hospital-based surveillance system for adverse events following immunisation and other syndromes, but it actually, I guess, won't be relevant until the vaccine is rolled out to children. There's the FREDS, Public Health Real-Time Emergency Department Surveillance, Syndromic Surveillance System, and that's basically an ED triage-based surveillance system which kind of mines triage data for words like immunisation, vaccine, other things that are related to syndromes, and looks for any signals within ED presentations. We suspect that there may be some modified clinician reporting obligations for COVID vaccine. We are yet to see what that looks like, but guidance for clinicians on your reporting obligations will come shortly, we're sure of it. The other thing is obviously active surveillance platforms. So rather than just waiting for patients or vaccine recipients to report symptoms, these are actually surveillance platforms which prompt people who've received the vaccine to report any symptoms. So they're sort of more of an enhanced surveillance. And VaxTracker and SmartVax both feed into the AusVax safety system, which is essentially it's a fantastic system which I think was initiated by a GP in WA, Alan Lieb. But anyway, so it's essentially a system of sending SMS follow-up to recipients of vaccines, which then collates reports back into a surveillance system. And so the frontline workers and healthcare workers will be all reporting back through VaxTracker, but SmartVax is a tool that's used in general practice, and would certainly encourage you and your practice to investigate signing up to SmartVax, which basically, would just mean that your patients would receive that SMS. All of the patients that receive the vaccine would receive a prompting SMS, and that would then provide a very high level of confidence in, that we weren't missing any adverse events that were just not being reported by people. There is also going to be an infrastructure of some expanded expert guidance for vaccine adverse events. So there is a specialist immunisation service, NSWIS, which is based out of Westmead Kids, I believe. And that service will be enhanced to be able to respond to calls outside of hours, and also to provide expert guidance to clinicians within hours with questions about, APHIS following COVID vaccine. And New South Wales is also investigating being able to set up an expert panel to very closely examine any vaccine signals that might be emerging from this vaccine. So there'll be a very high level of scrutiny and surveillance applied to the vaccines when they are rolled out. I won't dwell on the Australian rollout. Most of you would have now been aware of the national roadmap and the variously named phases of it, which I don't know why it wasn't just 1, 2, 3, 4, 5, but anyway. So there's 1A is really all that's kind of being talked about at present, given that there is still a lot of uncertainty in terms of, which vaccine, what the supply arrangements will be and what the according logistics will be with that. My understanding, and John may be able to supplement from a PHN perspective, but my understanding is from New South Wales Health perspective, New South Wales Health will be establishing hubs that will be responsible for vaccinating border workers and also the frontline healthcare workers in the priority subgroups. And currently the indication is that's basically ED clinicians, people who work in ED, should I say, including ancillary staff, people who work in COVID testing clinics and respiratory clinics is my understanding. But those healthcare workers will need to present to those designated hubs to be vaccinated. And at present, I believe 11 have been identified in the Hunter New England Central Coast footprint. The only one is the John Hunter, and the other nearest one is Hornsby that's been identified, but we still don't know. For now, my understanding is that just Liverpool Westmead and RPA are sort of the first cabs off the rank, and they'll be immunising people working at quarantine facilities. So that's sort of the current sort of New South Wales Health remit. The Commonwealth is taking carriage of the rollout to aged care. And then, yeah, as I said, 1B, we're still awaiting further details about 1A. So we haven't made too many more plans beyond that, although there's obviously a lot of discussion and thinking that's happening at present. The last slide that I wanted to finish with was just an interesting representation of data. So this is a graph representing survey respondents agreeing with the statement, if a COVID-19 vaccine were made available to me this week, I would definitely get it. And it's broken down by country of respondent. And interestingly, I note that Australia is sitting there at just above 50%. And you can actually look at the time series of this data. Again, it's from the Our World in Data website. And it seems that proportion that would get the vaccine if made available to them this week has actually declined slightly over the past few months, and I suppose that's concerning to me personally in terms of, you know, whether or not the communication has been as clear or as timely as it could have been, but also wanting to acknowledge the very central role that you as GPs play in and, you know, and as immunisation providers play in empowering your patients to feel confident in those decisions. And so we hope that this session tonight will equip you with the information that you need to have those conversations, because there is strong evidence suggesting that one of the key determinants of whether or not someone has the vaccine is whether or not their general practitioner recommends it. So I think I'll just stop there and leave you with that thought. And I think it's on to John now.
Thanks, Kat, and thanks for that update. Very much appreciated. Charles, if you wouldn't mind just going to the next slide, thanks. Thought I'd just give you a bit of an update on the ELI status for vaccine rollout for 1B in our region. Our region had 281 eligible applications out of a possible 334 accredited practices, which is approximately 84%. The ELI closed and the data has been submitted to the Department of Health for review, and those reviews are occurring this week. Practices will be then advised if they meet the criteria and are eligible to administer the vaccine. And subsequent to that, they will be advised which phase of which tranche of rollout they are to be in. The expectation is that initially there will be a small number of practices in each PHN, and these will be known as tranche 1 practices. Noting that, of course, we need to ensure there's a good geographic spread and an appropriate mix where the at-risk populations are. We also need to be cognizant of where the GPRCs are and state health hubs or vaccination clinics. It's then expected that as the production of the vaccine increases, the number of sites being able to deliver the vaccine will also increase. Next slide, thanks, Charles. Just thought I'd give you a quick update on the other EOIs and processes in play at the moment. The Aboriginal Community Controlled Sector and GPRCs have submitted their request for information to the department. That's being assessed, and we anticipate being told by the end of this week what the outcome of those are, and where Aboriginal community controlled organisations and GPRCs have been successful in our region, and we'll communicate that as soon as we can. We've also been asked a little bit about the pharmacy EOI. Just want to note that the PHNs don't have visibility over this EOI. It's being run by the Pharmacy Programs Administrator, the PPA, which is an agency of the Commonwealth Government. That EOI is solely intended to identify community pharmacies capable of participating in phase 2 of the rollout. and is scheduled to commence from May this year. That particular EOI closes on the 19th of February. What I thought I'd do now is just answer some of the questions that have come into me over the last week, and I thought we might just go to the next slide. Thanks, Charles. So I've been asked about mandatory training. When will it be available? The core training module is available now, and the AstraZeneca specific module will be uploaded as soon as the TGA have approved that particular vaccine. The Pfizer module is available now, and that may be of interest to GPs in general practice, although GPs in general practice by and large won't be asked to administer the Pfizer vaccine. Been asked a question, can Medicare be billed if the patient is seen by a nurse and not seen by the GP? Look, that's a very common question, and we've asked the department for explicit clarification of that question, and we will keep asking the question until we get an answer that we think completely answers that question. I have to note there is no separate item number for nurses at this point in time. Next slide, thanks, Charles. Can a registered nurse who is not an authorised immuniser administer the vaccine? The EOI, and this is a complex one, and Paddy's going to help me out a little bit here, but the EOI requires the person administering the vaccine to be an authorised immuniser. In New South Wales, the authorised immunisers are determined by New South Wales Health, and we today sought clarification on whether a nurse, registered nurse, working under the instructions of a general practitioner can administer the vaccine even if they are not an authorised immuniser. As soon as we get concrete clarification on that, we will get that out to you. So that's a bit of a work in progress. Thanks, Charles. Another question I've had is, will I need a barcode scanner? Look, the short answer to that is that we're aware that some of the clinical desktop software has been updated to include what's known as a serial field. That is about 108 characters long, and that's in addition to the batch number field. So what we've determined to do is see whether or not we can scan into that field using our sandpit version of the desktop products. What we don't know at this point is whether the barcode on the product will be provided in either the linear barcode or a QR code, or whether in fact it will just be a series of numerical digits. On the right of the screen, you can see a shot where I've highlighted the fact that the serial number is part of the desktop software, and at the bottom, interestingly and somewhat confusingly, the Pfizer vaccine has both a QR, a linear barcode, and the digital, the numbers and characters. So at this stage, we're not sure what the packaging is going to look like. As soon as we do, we will be able to give you a definitive answer. In the interim, we'll test the scanners to see whether or not they can input into those fields. It's a process that requires the desktop software to have undergone some changes, which leads us to the point of you need to probably ensure that your desktop software is the most current possible version for your particular product. Thanks, Charles. Can we co-bill for a consultation? The answer for 1B is clear, that there is no co-billing permitted. We've not received explicit advice on phase 2 onwards. However, I just wanted to note for you that the current pharmacy EOI for phase 2 onwards states that consistent with the government's commitment that the vaccine will be free, pharmacies will not be permitted to charge a co-payment for vaccine administration where it's part of a service, where any part of the service is delivered through any other federal, state or territory or private program that cannot claim against the program as well. So that's for noting, but we are seeking clarification about phase 2 onwards co-billing questions. Thanks, Charles. We've also been asked what are the requirements for immunisation certificates, and short answer is that the patient can get their immunisation history statement, and I've put in brackets a certificate there. They can either get that through their Medicare Online account through MyGov, or through the Express Plus Medicare mobile app. I logged in today, and in my account there are, and I went to it from both sites, from the MyGov site and from the app. You can see a copy of my immunisation history there. So hope that answers that question. Just wanted to talk a little bit about residential aged care. We're aware that the InReach provider for residential aged care has been selected, and will be advised in the next couple of days who that will be. And we will then be able to start the meetings with the residential aged care facilities, the InReach workforce, our local health districts, and ourselves, and any other key stakeholders, to make sure that we're all on the same page and working through the challenges of the vaccine 1A rollout to residential aged care facilities. The disability group home situation is slightly behind that. We're still waiting for advice on the Commonwealth on that particular rollout as well. Thanks, Charles. That's all from me from a prepared slide, and I think we might now go to the questions, and I might hand over to Patrick to facilitate those.
Thanks, John. Thanks, Kat. They were great presentations, and I think they've actually answered a lot of the questions. Thank you very much for the questions. Please keep them coming in. We might start off with Dr. Phil Usby from Maitland is asking a question about contraindications. Seems like everyone can have this vaccine. David, are there any contraindications to having any of these COVID vaccines, please?
The only contraindications currently, Paddy, for those 2 vaccines, and obviously only one we should stress has been actually got regulatory approval from the TGA, and that's the Pfizer-BioNTech vaccine. But both of them, in terms of WHO guidance, really it's only anaphylaxis. So anaphylaxis to any component of the vaccines. There's as we usually do with any other vaccines, one of the guidelines in relation to a person with acute febrile illness is rather to delay. The only other consideration would be somebody with a confirmed history of COVID-19, so documented laboratory proof. In those cases, it's not a contraindication, but one, if there's a huge pressure on vaccine, one could delay up to 6 months. We believe that there's a strong immune response, protective immune response, generally in people that have been exposed for 6 months.
Thanks, David. That's great. And while we're on vaccine safety, Kat and Dave, what about the safety of giving the vaccines to people on immunosuppressants or biological infusions, please?
So happy to go first. Look, we do know that COVID-19, one of the really high-risk groups for severe disease after elderly people is people that are immunosuppressed, either through health conditions or through treatment. Unfortunately, the early phases of the trials didn't really consider immunosuppression as a major subgroup, and that's not surprising. That's the usual way that these trials are rolled out. The Pfizer vaccine trial, as well as the AstraZeneca one, did include HIV positive individuals who were stable. So there's a group, but really there's no theoretical reason not to give these vaccines to people who are immunosuppressed. Neither vaccine is a live vaccine. The AstraZeneca vaccine, which is obviously a vectored vaccine, is a non-replicating vaccine. They've actually removed 2 of its genes, which means it can't actually replicate in the human body. So there's really no theoretical reason not to give the vaccines. Clearly, at the moment, the big rollouts in Europe and the UK and North America are gathering a lot of data on people who are immunosuppressed, and so far no safety signals have been detected. So we're lucky in a way that these huge rollouts, as Kat mentioned, the millions of doses that are being given with good surveillance systems, safety surveillance systems, really put us in a very strong position.
Thanks, Dave. And I just also mention pregnancy, I suppose, is another question that tends to come up. My understanding is that it's category B1 in that there's, insufficient evidence either way. My understanding is no, as you say, safety signals, but given the position that we're in Australia with, not having to rush these vaccines necessarily, it's really a matter of individual risk assessment with the pregnant person.
Thanks, Kat. So Kat and Dave, about the capacity of Australia to immunise the population and safety, if practices are so busy vaccinating, should people wait for 15 minutes afterwards? And the statistic here that it would require participating general practices to administer 50 doses a day, 7 days a week for 6 months. So it's going to take a long time. Have we got the capacity to do this, and do people have to wait?
Well, if you take our Prime Minister seriously, we have the capacity, Patty, and it'll be delivered before the last quarter of the year. I think it's going to take an incredible effort. I think that the supply chains, we know every time a new vaccine is rolled out that things are promised and we never quite get it at the speed that we want it. And we're already seeing that. So obviously we've had interference from the European Union, but Pfizer itself has tried to really ramp up its production and almost double it for the end of the year. So wants to really get to the order of well over 2 billion doses. And that's part of its commitment to COVAX. So Pfizer has now made a commitment with AstraZeneca to COVAX. And part of that is to provide affordable vaccine across the world. So I think that what was initially considered to be a flood of Pfizer-BioNTech coming into Australia will be more like a trickle. And I think that timeframes that are very ambitious will probably be drawn out a little bit longer, but I'm always optimistic and hope to see most people given the opportunity to be vaccinated who want it by the end of the year.
Thanks, Dave. That's great. And on the equity issue, Australia has responsibilities in the Pacific, and I know, David, you're very involved in this. There's a question here: how many vaccines is Australia planning for the Pacific and Timor-Leste, please?
Yeah, look, it's one of the things I think we can be proud of, Paddy, is that we've made not only a substantial contribution as a country to COVAX, we may benefit from that. In some respects, COVAX is a bit of an insurance in case all the horses that we'd invested in were like the Queensland clamp vaccine, we'd be begging COVAX for our bit, but we won't need that. So we're going to have capacity ourselves to produce vaccine. We've seen that there's an increase from 10 million to 20 million doses of the Pfizer-BioNTech that Australia has secured. But the good news is that we've not only invested in COVAX, but we've specifically invested more recently, actually $500 million in actually being able to not only provide vaccine, but support the rollout of vaccine across the Pacific Islands, to Timor-Leste and beyond. And that goes beyond just the vaccine itself. It's to support surveillance and to also support the infrastructure. So this is something which I'm very pleased to see Australia doing. Clearly, it counters vaccine nationalism, but we shouldn't ever rest on our laurels. And clearly, Australia can play leadership from an advocacy perspective in our globe as well.
Fantastic. Thanks, Dave. And another question on dosing, Kat and Dave. We don't have any insight because the AstraZeneca vaccine's not approved by the TGA yet, but what do you think will happen with the half dosing of the TGA, of the AstraZeneca vaccine?
Look, I can start on that. So I know that AstraZeneca is not actually put in for regulatory approval with a low dose or the half dose. It's quite clear that a secondary analysis of all of the data, which I've fortunately had a vision of, suggests that once you take account of the delay in dosing interval, the difference between standard dose, low dose, standard dose disappears completely. So it really appears to be, and there's a good immunological basis for that if you delay the second dose of the AstraZeneca vaccine for 12 weeks, you actually get a much better efficacy measure in the order of the low 80%. That's really what we want versus 62%. Now, what the regulator will decide is still open. Obviously, the AstraZeneca data, it was an interesting thing. One of the problems when you roll out trials, instead of doing them one after the other, one followed by two, followed by three, and you run them one and you start your two and you cover it with your three, is that you don't get ideal situations. And I think that's what we've seen with AstraZeneca. However, they are accumulating further data, lots of additional data, and that is in some high-risk groups. It includes a pregnancy register, it includes younger children. So we're going to get a lot of data, but I think that the timing of the dose is going to be critical, particularly where we're not seeing people dying all around us. This is an opportunity for Australia maybe to really get an optimal dosing schedule. Kat, you may be on mute.
Yep. All right, we'll just while Kat finds her voice. Are you there, Kat? No, we'll just move on with another question while Kat just gets organised. John, so for you, are you still there, John?
Yes.
About opportunities for employment. Are private companies going to employ nurse immunisers to roll out the COVID vaccine, please?
We know that a number of private companies have been engaged by the Commonwealth to roll the vaccine out to residential aged care facilities. They're well known and they're already out there. In terms of vaccine, general rollout of vaccine, the focus at the moment has been on general practice, and we've seen the pharmacy one, EOI, being scheduled for May. I wouldn't rule it in, I wouldn't rule it out, but at this point I've not heard anything to support that model.
Okay, great. Thank you very much, John. There's a question here about Coffs Harbour having a hub. Yes, that's correct. So the closest hospital hubs for the Pfizer vaccine, John Hunter, Hornsby, Dubbo and Coffs Harbour. They're the four in this area. There's about 8 or 9 in New South Wales. David, there's a question here about from a GP who has a new patient who wants to avoid being vaccinated because he has lymphocytosis. Do you have any insight into a specific presentation like that, please?
Look, I think what we probably would be doing is in cases where there are individuals with particular hematological conditions, these would be the occasions where the NSWIS line is going to become vital. And Kat mentioned this. I think what we've seen, even in terms of the risk groupings by medical condition, this is very incomplete at the moment. So I'd expect we're going to get a lot more detail about particular groups. There is no real reason not to give a vaccine in that situation, but I think what we will be doing is making it very clear to our GPs how they can get expert advice, and NSWIS will be able to provide that. They're going to be ramping up the expertise that's available, which will go more broadly than just normal. They're wonderful pediatric vaccinologists, they're going to be immunologists and other clinical specialists that will be able to support the rollout of the vaccine as well.
Great, thanks, Dave. Kat, we've got an amazing audience out there. There's lots of Olympians apparently wondering whether they can get their vaccine before they go to Tokyo. But there's also people that work in the home and community and aged care and disability sector. What about when will those both residents and staff be able to get their vaccine?
Thanks, Patty. Can you hear me now?
Thanks, Kat, that's lovely.
I am also going to promptly shift that one on to John. As I said, the Commonwealth is leading that part of the rollout, so we'd be very interested to hear his thoughts.
So what we know is that the workforce, the ImReach workforce for that particular rollout has already been selected. They're ramping up their logistics arm. The workforces for the, we're not sure of their particular model at the moment. We'll need to get that from them, but what we anticipate is that they will work across our region and will vaccinate on site. They will bring the vaccine and all of the other material with them. They will have connection up to the AIR, so the records will be uploaded at the site. In terms of people who live in the community, so those who are not, elderly people who are not in residential aged care facilities, those who can and are able to go to a vaccine clinic or their general practice, they'll be encouraged to do that. We're just not sure at the moment about mobile services, but we're working through that with the Commonwealth as well.
Terrific, thanks, John. And there's a specific question here from Dr. Tony. Do we know when the funding model will be finalised? We've submitted an EOI, but we'll have to consider withdrawing if the funding model continues to be unviable for general practice.
Well, the funding model is what was in the EOI.
Okay, great. Thank you. And some questions for Aboriginal people. John, we know the AMS is an opt-out situation. Do we have any insight into whether all the AMSs in the area will be able to provide vaccines yet?
We haven't heard from every AMS, but the vast majority have indicated that they will participate. I wouldn't like to say all of them, but the vast majority across our region have indicated a willingness to participate. Great. I might also add, in terms of vulnerable communities, we're working with Darling Downs, Westmoreton, PHN to ensure that the border communities up around the Gundawindi, Toomala, Boggabilla are also able to access vaccines, and the two PHNs are collaborating to make sure that occurs as well.
Fantastic, thanks, John. And Dave, with Aboriginal people haven't been included in the trial. So is the vaccine safe for Aboriginal people? Is there any reason to think it won't work as well, or that Aboriginal people will get sicker from the vaccine than other people? There's concerns out there about the vaccine if it's untried for Aboriginal people.
So the good news is that both the vaccines that are going to be approved, plus the other vaccine that Australia's got pre-purchase on, the Novavax, have all included people of different ethnicities, Paddy. And we really know that an amazing job has been done by Aboriginal people, First Nations people in Australia to keep safe from COVID during the first wave. The last thing we want to see is people that we know are vulnerable, both from historical pandemic, huge burden on Aboriginal people, but also because of underlying health conditions that they're not protected. So I agree completely with the federal government that Aboriginal people, on basis of risk, really are a high priority group. Clearly, it's going to be really good that there's a dedicated, Kat mentioned the dedicated surveillance, safety surveillance that is going to be in place. And we're hoping that that data will be shared regularly with the community and with providers to make sure that they are aware that of the safety of the vaccine. So I think we want to get those messages out regularly as people are vaccinated. The good news is that overseas, obviously, there have been Indigenous populations that have been target groups for initial vaccine rollout, particularly in North America, and there have been no safety signals in those groups either.
Wonderful, thank you, David. Yeah, if general practices are interested in using SmartVax, please contact me and I can put you in touch with those people. And the Vax Tracker program will be up on with all the public Pfizer hubs in New South Wales. So looking forward to some good data from that, and we'll be reporting that directly to the TGA for them to keep an eye on safety. Kat and Dave, what about Kat talked about pregnancy. What about breastfeeding? People breastfeeding.
Oh, yep. My understanding is that there's no contraindication in people who are breastfeeding.
Yeah, and I'd support that, Paddy. There's no biologically plausible reason to consider there being a risk, and certainly there've been no safety signals.
Wonderful, thanks, Dave and Kat. And Dave, good to know about the efficacy that Kat presented. What about the efficacy for people who are not exposed to COVID, like hopefully be the situation in Australia?
Patrick Cashman, you're going to have to interpret that one for me.
Yeah. Okay, I read it verbatim because I wasn't sure myself. So I guess efficacy you can really only test if you're challenged with the disease.
Yeah, look, the efficacy, the trials that have been run, and look, I'd encourage everybody who's really interested to have a look at the papers that have been published, particularly the phase 3 studies. They were quite rigorous. I think the efficacy estimates are pretty good. I mean, the Pfizer's quite extraordinary. I think it was 170 cases. 162 of them were in the placebo arm and 8 in the control arm, and there were no severe. I think that's the important thing that Kat showed. No severe disease in people who've been vaccinated in either of the 2 vaccine groups. Now, that's going to be tempered by the emergence of these variants, and we saw that South Africa, everyone would have seen that, have stalled the rollout of AstraZeneca vaccine, because their dominant strain now is the horrible variant of concern that Kat mentioned. But the interesting thing there, even though that was a very small study, 2,000 odd people, and Shabir Mahdi presented this data one night this week, they only had enough cases of mild disease to show the difference. They weren't looking at severe disease. And it's very likely that in the field, this vaccine would still be highly protective against severe disease. What it does do, I think, is it won't lead to elimination of COVID. It will lead to an attenuation of COVID, and it could become, as what people have said, is that if we get high enough coverage, we could see this becoming the new seasonal influenza. I'm hoping that won't be the case. I can already say that AstraZeneca is gearing up for a trial against the COVID variant in South Africa, which they'll be running out and hopefully have some results in May. So I think we're going to see the nimbleness of these vaccine producers, which has been quite extraordinary, is going to be accelerated as they try and overtake these variants, these mutations that are occurring. So I think it's an exciting time, and I'm certainly very the process that the TGA is putting the vaccine data through is quite extraordinary, and I think we should be proud of that as Australians, that both the rigor of the efficacy determinations and the safety reviews is first class.
Wonderful, thanks, Dave. And just a final question, because I think we've run over time. To do with what you just mentioned, that more people get vaccinated, the more protection the whole community has. There's a question here, if you're chosen or selected to have the vaccine, like say you're in one of the groups who've been offered the vaccine, are you able to decline the vaccine?
Yes, at this stage, there's no indication, that, at least in this first phase, that the vaccine will be mandatory. So it's by choice, and that's something that I certainly support. I do think, however, that we may find that certain frontline workers, maybe it might be a part of their requirements for employment. We already know for health workers who are exposed to bloodborne viruses, or who might put patients at risk, that there's a requirement for them to be vaccinated if they work in a New South Wales health facility. We know that aged care workers now have to show evidence of their annual influenza vaccination. So I think that this may be something in particular high-risk settings that down the track we might see some levers, either sticks or carrots, pushing people to be vaccinated.
Wonderful. And for healthcare workers around this video conference, you really show a lead in your community. So it'd be really consider the vaccine very seriously. So let's throw back to John and Charles. Thank you very much, Kat and David. That was wonderful.
Thank you, Betty.
Thanks very much, Patrick. And thank you everyone for popping your questions in. That was a really valuable discussion. I'd also like to take the opportunity to thank Patrick, David, Kat and John for generously giving your time this evening. We appreciate you're all very, very busy. So just a reminder that there will be an evaluation survey that will pop up as we end the webinar. If you could just take a moment to fill that out, we'd really appreciate it. So thanks again for joining us, and good night, everyone.
Thank you.